Okay, we're finished with all the pricks. Good. I'd like to invite Deb Cole back to the stage to give the award initially for the best emoji. Is that right?
So I was very fortunate in the fact that I got to be the judge, and I love this one. So this one is by Shantaine, is that right? Is Shantaine here? Over here. I have a prize for you, so you have to come and get it. So I'll give it to you afterwards. So thank you very much for all those people that participated in the emoji prize. So hopefully you'll use that when you get home.
Come and have a seat.
I'd love to.
We've got the microphones ready because this can be a whole of room discussion as well. So when you're ready with microphones, just join in. So it's kind of a recap of the day, but also some of the issues that might arise and things moving forward. Feel free to challenge. I can't see over there, so I will. Somebody will need to tell me if there's a question from over there. So, Deb, your reflection on the day?
Well, I think it was a pretty good day from my perspective. One of the things that I found was that people, we shared a lot. Lots of people shared their ideas and some of the innovations in the sector. And I think there was an acknowledgement that it's not going to be easy. There's a lot of work to do. But I also think we were a bit challenged at times. I found that some people didn't like some of the messages they were hearing.
Well, let's pick up on that. I mean, the conversation with consumers was challenging.
It was challenging. And I think we've got to hear that message. It's a really important message to hear because we quite often, when we're in the clinical environment, most people aren't going to tell us at that point in time, this is really awful, or that it wasn't what they expected. And some of the messages I got out of that was, well, a number of people received care and they probably didn't actually know why they were getting it or what was happening or what the expectations were. And we've got a lot of work to do, and particularly in value-based healthcare, if we are going to truly co-design or co-produce care, we actually have to have a much better understanding of how do we talk and communicate with people. And I keep hearing when I speak to people at different stages is, oh, you know, I'm already rolling out, or I already undertake person-centred care or patient-centred care. And yet we hear from our consumers today that, well, maybe we haven't actually been that good at it, and maybe we need to get better at it. And I'm not saying it's easy, it's actually really hard to listen.
But if you're sitting there and many people in the audience probably thought they are doing a really good job,
Yep.
They're trying hard,
Yep.
and it's a bit deflating to hear that message.
Yeah, it is. But I think that if we heard David speak a bit earlier with the clinician, he's been practicing for a long time. As he said, he's heard this stuff for a long time. And it's that same old thing of Albert Einstein. If we keep doing the same thing, we're going to get the same results. And those are stories that I've been listening to most of my professional life too. And we've got to break that. We've actually got to make it something where everybody actually understands and can move forward and communicate properly. And it's not going to be easy for a lot of us. It's going to be, I was talking to someone earlier in the day, it's a bit like turning around and saying, stop smiling that way, smile a different way. And that's really what we're talking about. It's going to be challenging, but we have to change it. We can't keep having those stories coming. We will for a while, but there's got to be less and less of them.
But it's more than just good communication.
Yep.
I mean, we heard stories about quality of care.
Yes.
And we saw stats, so either your stats or Zoe's stats about variation in care.
Mm.
I mean, that's a big job.
It's a very big job, and that's about looking at the data that we have, and we've got a lot of data. We've got so much data we almost drown in it. But we've actually got to start looking at it and going, what is it telling us? And we have to challenge ourselves. And you heard some of the clinicians today talking about, you need to look at this stuff. What is right? When you see that variation, is it the low figure that's improving health outcomes, or is it the high figure? We don't actually know. We actually have to have those conversations. We need to start measuring health outcomes and say, have we actually made a difference? So I think you opened the day with talking about 30% of services are low value, they're not actually needed. And that would be the case in dentistry too. We know there are things that we do that do not make any difference. We shouldn't be doing them, because for every one of those services we do, we could be treating somebody else. We could be actually improving the community's health by treating somebody else with that time. But we get into habits of doing the same thing, and it's easier to do it that way. So we do need to start really thinking about it, and it shouldn't be from, you know, the top or the executive or the, you know, the senior people. It should be clinicians themselves challenging the work that they've got, looking at their data and saying, is this really adding value?
It still feels a bit abstract to me when I hear you talk about it.
Yep.
Make it tangible.
Well, one of the ways that I would imagine it is that there's a group of, lots of people have been involved already, but clinicians need to determine what are their clinical pathways. You know, so for particular patient groups, what sort of services will we be providing? What sort of materials will we use? What techniques will we use? And that process is already there. And most of this stuff has been around for a long time. What we're doing is pulling it all together into one packet, and then turning around and going, and we're going to follow those pathways. We're going to do that. At the moment, the variation shows we're not following pathways.
So statewide pathways rather than localised pathways?
Yes. There's lots of people being involved in all of those now, right across the state, of developing, and they're actually pathways that have been published in journal articles across the world. So we're not talking about inventing something new. These things have been around for a long time, but we're not following them consistently.
And what about the introduction of new technology and being able to afford that? I mean, if you could save 11 minutes an hour by introducing of each person's time, I mean, that's an enormous amount of time by introducing digital radiography, for example.
That's right. Well, some clinics already have digital radiography, and I know a number of you have gone, well, you know, just get on with it, and that's easier said than done. And in the hospital now, we're about to bring in those. But one of the reasons why Nuno, who you met earlier, is now here is he's looking at, you know, electronic medical records, all of the connections. If we're going to start collecting health outcome measures, we need to be able to have it so it's simple and easy, and so that you as clinicians can actually use that data on a day-to-day, patient-to-patient basis, having discussions and sharing about, are you actually carrying out interventions that will make a difference? So, but we need to have the technology to do that. The government's actually been very supportive and has provided us with some really good funding to do this, and we're in the process of doing it at the moment. We're not going to have everything perfect, but we're actually being given quite good funding to actually get that underway.
Have you seen models in practice, either here or in other states or overseas, where you say, well, with exactly the same resources, we could see more people for better outcomes?
I've probably seen little bits and pieces. One of the advantages I have of sitting on this ICHOM group is we work with 25 different countries. And so I've been talking...
So this is patient-reported outcomes?
Patient-reported outcomes, clinical-reported outcomes, and sort of adverse event type outcomes. They're the sort of three types of measures. But there are people from throughout the world, 25 of us, sit from every different continent. And they're people that are going through, including consumers. In fact, a couple of our consumers are here as well, that are involved in it as well. And what we are doing is trying to find the best patient health outcome measures. But also on top of that, we're discussing who's doing what where. So we are getting to see a few places that are actually starting to roll this out. This is probably, we're looking at statewide, so we're talking quite a large rollout. But the reality is, I think there's so much push around the world now about value-based healthcare. It is time to start moving in that direction.
And what about the piece that we spoke about a lot earlier, which was, you know, the Michael West research, which is that if you've got engaged staff that actually care for each other, and so this is not soft stuff, this is actually care for you. You know, you're going through trouble, I care about you, and you are working in a coherent team where there's emotion involved between you positively, that you get better outcomes. And so how do you move that in that direction?
I mean, for those of you that work in Dental Health Services Victoria, you probably know that for the last couple of years we've been running Respectful Workplace Days, where we actually made a decision to close down the hospital for a day. That's a pretty intense decision to make. And to begin with, that was quite challenging for a lot of people. We've closed it down for the day except for emergency, and we take everybody out and say, let's reconsider the way that we're going to act with one another, with the view that that's also going to be how we're going to act with our patients going forward. We recognise the fact that, I mean, a little bit what Karen was saying before, sometimes we send a lot of black holes to people, and we want to move it towards more stars. And it's easy, once again, it's easier said than done, but it's part of the process we're going about it, saying that we've got a set of values, let's live those values. We won't always get it right. It is hard, but we do need to start treating one another more respectfully, and then we can start working with our patients more respectfully.
And what about that balance between protocol, according to evidence, which is a way of reducing variation so that you do what you know works, versus giving clinical freedom to say, well, you know, the point I made to Belinda earlier, which is that, you know, you might have quite rigid appointments which are about examination and diagnosis and treatment planning, when you could actually spend 50% of the time on, you might as well just get straight into treatment and do the seal or do a quick filling and move them on. But the protocol doesn't allow you to do that because this is only about diagnosis.
I think one of the things that the discussions I've heard from the people designing the clinical pathways is it's about who does what bits. Like traditionally, we are very dentist orientated as an organisation, but moving to having different people doing different parts of it. So the interactions can be done by different people. And I think we've seen models in other, like North Richmond, and I know a number of other clinics are already starting to do quite revolutionary and transformative ways of carrying out all the tasks that need to be had. But that doesn't take away from the fact that I think if there's an evidence base, you should go down a particular way. I mean, my experiences in general health, in general hospitals, is it used to amaze me that people would come in with, you know, cardiac or suspected stroke, and there's a really classic stroke pathway, and very few people followed it. And yet you know that the outcomes, the health outcomes of that, are significant just by following something that's really good evidence. We're the same in dentistry. I mean, if I could run data now that says, let's look at all the high-risk children in the state, and I could guarantee I wouldn't find every one of those kids having fissure sealants on their 6-year-old molars and have had a fluoride. And yet that's really what should happen. So that's the sort of thing that we need clinicians to sit down as a group and go, these are the things we need to do, and then we do need to abide by those pathways.
And that calm environment, I think that Stephanie talked about, when people come in the door, that just, no matter what the pressure is on the system, once you're in the door, it's a very different feel.
I think that's actually possible. I really do. When you look at the way that we've processed MAP through the current state, what it looks like, and having been involved in the old dental hospital quite a few years ago, some of that stuff was designed back then. Like what we've just done is added stuff on. We've added busyness into our lives. If we can take out the 11 minutes of walking, if we can take out all of these systems and processes we have, it can be amazing how much calmer. And if we actually treat one another respectfully, that brings a calmness too. There will always be emergencies of people coming in, but once again, you can manage those well because a lot of it's actually relatively predictable. I know that people argue with me on that, but you look at emergency departments around the world, there is a degree of predictability about what comes in the door. Not every day, but most of the time. So some of that's about us standing back and planning how we might make this better and bringing a lot more calmness to it. We want the innovation to be in designing how we're going to adjust the clinical pathways, how we might improve the way we treat people.
It's interesting. I get the impression from some corporate dentistry practices that they're making the same mistakes and not and not doing this, which surprises me in a way.
Well, I think that
It's like cookie cutter. It is like cookie cutter dentistry.
I don't think we do it a lot differently because we're funded on the same way, which is basically a fee-for-service type funding model. And so we are all incentivised to provide volume. We're not actually incentivised for value. And so one of the things we want to do is to move towards a world where we get paid to improve people's health outcomes, not paid to, in fact, do more things on people.
And do you think you have the right... Is it time to re-examine... So you've got traditional craft groups, you've got dentists, you've got oral health therapists, and so on. Do you think it's the right mix, or it's time for innovation in the people you have in there? So would, for example, having a general practitioner in a clinic help? I don't know the answer to that question, but that's sort of lateral thinking.
Well, I think there's two. There's one practitioner that we are working on at the moment, which is oral health educator or coach, and there's a number of people in the room so they can provide quite a lot of work within the dental clinic. But I think dentistry has actually been quite insular in the way that it interacts with the rest of the health profession or even caring profession. And I mean, that's changing now. You can hear a lot of that language where we realise now that the mouth has been excluded from the body, apparently. But for us to, and I hear quite a lot from practitioners, they go, well, no one ever refers patients to us. But if you actually ask, well, how often do you refer out to a diabetes educator or a GP or anything like that? And it's pretty rare. And we need to actually be much more connected. GPs see almost everybody that is eligible for public dentistry, and we're only seeing 30% every 2 years. So if we could actually interact with GPs to do initial screening, that would make a huge difference if they had the right information.
So are you working with PHNs, primary health networks, to see if you can actually spread the love a little bit?
Yes, we are. And in fact, we're doing, a number of other states and jurisdictions are doing a similar thing, working with the PHNs who are developing the pathways and developing oral health pathways for GPs in their practices so that they can actually identify and refer on from an oral health perspective. So that's work that's being done here in Victoria at the moment, but it's based on the pathways type model.
How necessary is it to have a dental chair to do some of the work?
Well,
because we talk about scope of practice being expanded within the profession, but you have this sort of piece of technology in a sense, which has kind of a holy meaning around it, which is the dental chair. How essential is the dental chair?
Well, dentistry itself is very procedural, and so for the procedural parts, it's pretty essential. But we've heard today many times that most of the disease we have is preventable. So if we could actually do most of it outside of the chair, we wouldn't need the chair. And I think
Or you could use the chair for other things.
You could use the chair for the other things, the procedural stuff that you have to use it for. And in fact, I think that when you look at the communication, trying to communicate to somebody to try and co-design something when you're in a chair, it's not a great place for communication.
Because if you can disconnect from the chair, you can also disconnect from the clinic and spread things further.
Yep. And there are people in this room that are already starting to do some of that work now. And that's, I think, where the real innovation is coming.
Any questions or comments for Deb? I can't see around the corner. Yes, somebody at this table here, if we could have the microphone, that would be great. Thank you.
not a box. Oh, I'm sorry. Dentistry is not a black box that you can just put on a shelf and sell. It's a health care. We provide health care. The consumers come to us expecting to purchase a consumer item. I mean, typically I get a family coming to me in the hospital saying, my child needs orthodontic treatment. They've been told by somebody outside that they've got a problem and we're here to fix it. We want your skills to fix this problem and we want it now. There's no consideration for the risk or the benefit involved in that process. It's a demand that's driven by consumerism. Now, step back, you need to consider other aspects of this child's care before you embark on an orthodontic program of treatment. Another example might be a referral from outside. This child is having an MRI next week. Please restore 6-5 distal while they're there. It's not a compartment. You have to take on a whole of life, a whole of person care program in order to get these sustainable outcomes that you're referring to. So consumerism, to me, I believe, has had a negative impact on our dental care over the last few years. The second point I want to make is engagement. And I particularly enjoyed the first presentation by Lynn, where she spoke very clearly and succinctly about the importance of that engagement and going upstream. We will spend upwards of 30 to 40 minutes of a new patient consultation going into a detailed medical history, a detailed dental history, a risk analysis, and try to identify those factors that are implicating on that child's oral health at that point in time. And often the comment that we receive back from our receptionist when the mother gets out to the mother or the father, I should say, not being discriminatory here, but when the parent gets out to the reception desk, well, that was a waste of time. All they did was talk to me. I wanted something tangible. I wanted you to pick up a handpiece, cut a tooth, or do something surgical. So the consumer, as you refer to them, is expecting a surgical procedure in most cases. Despite that criticism, we still persist in that model. We still seek to understand the reasons why that child might have severe early childhood caries, etc. So I think we need to step back a little bit. I guess my question, if I do have one after that commentary, is how do you balance the expectations of the parent with the situation, with the resources we're provided in this environment and get the best outcomes for these children? Thank you.
Right. Look, I don't think that when I'm talking about consumers, I'm talking about consumerism. I'm talking about respecting what the consumer wants. Like, if we're talking from a value perspective, it's about improving health outcomes that matter to patients. And we actually have to have that conversation with people. So I'm not saying that the consumer will come in and just buy the little black box. I'm saying that this is a co-produced type of treatment plan. And that takes time. Some of the examples I've seen in the States where they're using value-based healthcare in general practice, not in dentistry, but in general practice, very large examination up front, really quite intensive, but it pays off significantly with reduced hospital admissions a long way down the track. So you invest up front and then you gain at the end. So, but that's a whole new model of care. The other thing about it is...
Which you've got to set expectations for.
That's exactly right. That's the bit I was just about to say. My experience with people that have changed models of care, you need to actually explain what the model of care is. And the problem, and I think some of the conversations I think we heard from our consumers today, I don't think they had any idea what the model of care was they were working within, other than they were just expecting something to be fixed and it wasn't. They probably didn't know that maybe it was a temporary solution, may not have been either. But we don't actually explain what our model of care is or the process. And most communities that I'm used to dealing with, once people understand what you're doing, and I'm not saying that they like it up front. Sometimes people do walk in with expectation of what it was like in the past, and you need to take people on that journey with you. This is not going to be accepted by all parties, but in the long run,
sometimes you don't need it either. It's pretty obvious what you need, and you go straight to it. So
that's
you
right.
can't follow it religiously.
Exactly right.
But But I mean, hasn't dentistry been its own worst enemy, just like general practice? So general practice has become commodified, dentistry has become commodified because you make money by transactions, and your private dentistry has led you to expect that dentistry is just transactional. And you go in, you have your filling, and you go out. Slightly numb.
That's true. Slightly numb. But if you listen to the consumers today, they were saying they want to be able to be proud of what they look like. They want to be able to get a job. That's actually what people want, and they don't want to be unhealthy. They think that the way of doing it, because we've sold it that way, is that I get a filling and it will fix it. We've got a lot of work to do.
As I'm sure. But it also makes the practice more satisfying. Because
Yes.
it's not, this sort of model of care is going to attract clinicians who don't want to be commodified or in the transactional
Yes.
process.
Yes.
Any other questions or comments? Yes.
If I can just respond very quickly. We've heard a lot about expectation on the patient's point of view. What about responsibility? We don't hear that word mentioned at all. Patients have to take responsibility for their home care, and that's the point that needs to be driven home here. I'm not expected to go home and brush their children's teeth.
I think I said that in my presentation. There was an expectation of that.
Well, I'd like to hear
Yeah.
more on the responsibility as
Yeah.
well, and bring those
Yeah.
two together in this engagement process.
Yeah.
Any other questions or comments? Yes, over here.
Thank you. Gemma Kennedy from CoHealth. Just a comment. Yesterday in the workshop we talked about, what would it look like? And I think sometimes when we compare to general practice for medical general practice, dentistry is very different. And I think maybe we need to start talking about oral health care and it being a two-stage component. One is oral health care where we are educating, empowering and giving all those self-determination rights back to the client and supporting them through that process. And then there's very evidently still a need for operative, which is the dentistry side, which sometimes you just have to do that in a dental chair. And until, we have the social revolution that was talked about yesterday, that divide of people that don't ever need dental care and the people that, the 20% that need 80% of the work, until that's decreased rapidly, we're still always going to need people working in dental chairs.
Sure.
No, I totally agree with that. And I think that we're going to have to, I think sometimes actually spending time thinking about the parts of it that we can pull out of the dental chair, I think will help, because we do tend to, even a lot of our discussions go straight into the clinical treatment part, when in fact there's a whole pile of upstream work that can be done. In fact, I got some feedback from yesterday's presentation that people came up with a suggestion that, maybe we need to move towards like an immunisation before school. You need to have an oral health exam before you go to school, which would be an interesting concept.
Yes.
Oh, hi Deb, Shane Maguire. How are you? In one of your earlier slides you talked about funding on bundled care packages predicated on provision of high value care. At the same time, if we're going to start measuring outcomes, is there a view that somewhere down the track where clinics were able to demonstrate improved outcomes by the measures that are then embedded in the system, that bonus payments could be an incentive?
Pay for performance. Surprised it took this long for it to come up.
That's part of the discussion at the moment about what would be the funding model. Pay for performance,
It's not got a good track record.
no, it hasn't got a good track record, so I probably wouldn't go down that track. But what we're looking at is having a payment for, I suppose, just a general payment, which would probably be capitation type payment for a population that you'd look after. And then a component of payment, which this is the bonus part, which is you get paid for improving health outcomes.
Which is a bit like the PIP payment in general practice.
Yep. What we are looking at too is for things that require lab work, which is the expensive part, that'd probably be paid on top of that. This is all still fairly early days, but there's lots of people now starting to look at that going forward.
Deb, thank you very much indeed.
Thank you
Look
very
forward to
much,
having it
Norman.
rolling out.
Thank you.
And the day would not be over if Jamie didn't finish it. So please welcome Jamie back to the stage.
Thanks, Deb. Thanks, Norman.